This time we're going to discuss something different. So we're going to shift focus to recurrent or metastatic head and neck cancer. And we're going to mainly talk about the first-line therapy, although I'm going to discuss some data that are emerging on the second-line therapy as well and how to interpret this new information. So recurrent or metastatic head and neck cancer has poor prognosis. In historical data, we see reported median survivals between 6 and 9 months, and those are in the absence of targeted therapy, so those are older data. Patients rarely present with distant metastasis. As you know, this is a local regional problem, but after being treated for local disease, at least for local advanced disease, recurrence is seen in about 50% of patients, and then we see a good number of distant metastases as well. We did an analysis of patients treated on ECOG trials in the United States, and we identified a number of prognostic factors. Those include weight loss, performance status, primary site, tumor differentiation, and prior radiotherapy. We also have looked, and other groups have looked at the importance of HPV. It seems that HPV also carries a prognostic significance even at the setting of recurrent or metastatic disease. I borrowed that slide from Professor Vermorken, and we agree that in terms of what are the standard treatment options in recurrent or metastatic head and neck cancer, first of all, patients who can have surgery at recurrence should really get surgery. So surgery at all times if feasible. And then radiation therapy or radiation maybe plus targeted therapy, because this is re-radiation most of the time, could be considered. Then for non-resectable disease, we're left with re-radiation in many cases. And then the main treatment in terms of systemic therapy are agents such as cetuximab, platinum 5-FU that I'm going to be discussing with you. There are some patients who cannot tolerate such regimens because of compromised performance status, and in that case, at least before the immune checkpoint inhibitor data, standard approaches would be single agent therapy, either with methotrexate, taxane, or cetuximab. And for patients with very compromised performance status, maybe supportive care alone could be the best approach. Now, the major development in the field until recently has been the so-called EXTREME trial, the data published by Professor Vermorken back in 2008 in New England Journal of Medicine. So this trial was a phase 3 randomized trial for patients with recurrent or metastatic head and neck cancer, good performance status, most had performance status 0 or 1. And this study randomized patients to standard of care platinum and 5-FU, so either cisplatin or carboplatin plus 5-FU, or the same chemo regimen plus cetuximab that was given during the chemotherapy. The chemotherapy was up to 6 cycles, and then if patients did not have progression of disease, continue to receive weekly cetuximab until disease progression. You're well familiar, I think, with the survival data, a very important landmark trial showing that there was improvement in overall survival of patients. In terms of the median survival, there was an improvement from 7.4 months to 10.1 months, so 2.7 plus months with cetuximab. The disease control rate was 81% in the experimental arm. And in terms of responses, because that's important as well, objective responses, with cetuximab plus chemotherapy, there was a 36% response rate, almost double compared to chemotherapy alone, and there were 7% complete responses versus about 1% complete responses in the control arm. And that's meaningful because when we have objective responses, patients usually have less symptoms, and that was shown also here in the symptom control analysis, and there were certain symptomatology that was significantly improved by the addition of cetuximab to chemotherapy. In terms of toxicities, I don't know how familiar are you with this regimen, but it is an established standard in most of the world. There is rash, as expected. Of course, we see hypomagnesemia. That's also specific to EGFR monoclonal antibodies. There was also more infectious complications seen with the 3 drugs versus 2. Of course, there were some infusion reactions as well, but overall, manageable toxicities, reasonably well-tolerated regimen. I think most of the toxicities are what you see with just the backbone regimen of platinum N5, a few. And not surprisingly, as we did show earlier in the Bonner trial, there was no difference in quality of life between the 2 arms. So in this case as well, there's no difference in the, no significant difference at least in patients who received cetuximab plus chemotherapy versus chemotherapy alone. I think that's another important observation. About 100 patients in this study were went to receive maintenance cetuximab. Again, those were patients who did well and did not have progression of disease. And if you just take those patients, you see that in that phase, the maintenance phase, treatment is very well tolerated. You see a very small number of patients having a grade 3 or 4 toxicities here, and only 5% discontinued maintenance because of toxicity. So if you're able to go to receive maintenance therapy after concluding the chemotherapy part, usually you do well in terms of toxicities. And there was also an analysis of the P16 status of those patients, and this has been published as well. And as you can see here, it seems that the combination benefited both HPV positive and HPV negative patients. Of course, you know, the numbers are not as high to look statistically significant, but again, it seems that there are trends favoring the 3 drugs versus 2 drugs. So it seems that treatment works regardless of P16, that's HPV status. So I think we will all agree on this. I hope we all agree that this is a standard approach. And platinum 5FU plus cetuximab almost doubles objective response rates, extends progression-free survival and overall survival versus just chemotherapy alone, reduces the risk of death by 20%, and shows efficacy independent of P16 or HPV status. So the international guidelines, including the NCCN guidelines and the ESMO guidelines, have included the extreme regimen as a standard approach, standard of care, category 1, the NCCN guidelines, for the first-line treatment of recurrent metastatic head and neck cancer. I would like to remind you that when we say first-line treatment, we include patients with recurrent disease who relapsed 6 months or later after receiving radiation plus chemotherapy. And that's important to recognize. So if someone had relapse within that 6-month frame, was not eligible for the extreme trial. So early relapses usually behave poorly, and those were not included in the extreme study. Usually we consider that second-line treatment for practical purposes. So how long to treat recurrent metastatic disease? Well, in the extreme trial, it was done until progression of disease. So if you're going to use that regimen, I suggest you do that. And actually, if there was benefit, cetuximab maintenance could start even earlier than the 6 cycles. So if someone, for example, had a response, did well even after 2 cycles, and could not tolerate the chemotherapy, and chemotherapy had to be stopped, there was the option, and patients continued actually to receive cetuximab maintenance, and there's benefit. Again, there's no trial that looked at maintenance versus no maintenance. So if you do this regimen, you have to follow the way it was done in the pivotal phase 3 trial, and that was with cetuximab maintenance. And we have other examples from other solid tumors, and this is an example from non-small cell lung cancer. that shows to you that maintenance is an acceptable concept in oncology. There are some studies that have looked at every 2 weeks administration, and if you treat colorectal cancer, you know that probably that's fine. It has not been studied as well in head and neck cancer, but we have some data. So it seems that this is an option for certain patients that do not want to come every week. You can certainly switch to every 2-week schedule, and this seems to be well tolerated and probably will be equally efficacious. Now, what about using a taxane instead of the 5-FU? I'm not a fan of the 5-FU. I would personally prefer using a taxane. 5-FU is causing mucositis, and it's more difficult. You have to use the continuous infusion. So I think a taxane is a good option. Of course, 5-FU was used in the extreme regimen, and of course the taxanes and platinum agents are synergistic, and adding cetuximab to that combination is certainly of interest. So and that is shown in the laboratory as well. This is an older paper, but we don't have many of that kind, showing to you that a taxane plus cetuximab is synergistic. Actually, because we recognize the importance of that combination, back in the United States, we did a trial that was published in JCO in 2010. So we ran the trial of using the TPE regimen. So this is with cisplatin, docetaxel, and cetuximab. So 3 drugs, TPE, and we use that in the induction setting. So those studies are in the induction setting, but we did demonstrate that TPE is an interesting induction regimen. It has been further studied, including a trial by a German group that used it for laryngeal preservation, although they first used the TPF plus cetuximab. That was too toxic, and then they dropped the 5-FU, again suggesting that maybe you can dispense a 5-FU. You probably don't need it, but again, we need more studies on that. So the GORTEC, based on what we've done in the United States with TPE, used TPE in recurrent or metastatic disease. So they first ran this phase 2 trial, and they used the TPE regimen, so cisplatin, docetaxel, and cetuximab for 4 cycles. So all those are being given on day 1, and then you continue with weekly cetuximab. Then 4 cycles, and then continued with maintenance, and maintenance in this case was done every 2 weeks. So they simplified that regimen. They used double the dose every 2 weeks. That's not the approved dose. And in that phase 2 trial, that was a 54-patient trial that demonstrated good responses, so 54% response rate, pretty good. And then also a median overall survival of 14 months. So very promising efficacy data from that study, again a single-arm study, of course. And then we have more data using a taxane in the combination, and those essentially kind of replicate that experience of showing very high overall survival with those combinations. And this is an example of a Japanese trial that used carboplatin and paclitaxel, so the other taxane, with cetuximab, and that again showed a very high survival, a median survival of 14.7 months. This paper was presented at the ASCO meeting 2016. The ongoing phase 3 GORTEC trial is comparing the TPE regimen to the extreme regimen. They use the TPE regimen, actually they call it TIPEX, it's easier to say TIPEX I guess in French, and they use it exactly as it was done in the GORTEC phase 2 trial, so 4 cycles of this regimen and then continuing with cetuximab maintenance every 2 weeks. And then the control is exactly the extreme regimen, as was done by Vermorken et al. This study is accruing pretty well in France, but also has opened, I understand, in other European countries, and hopefully is going to present results in a couple of years. Now, just a quick review of cetuximab monotherapy. I'm not sure if you have used it. It's an approved indication, at least in the United States. So cetuximab by itself has some moderate activity with an about 13% response rates. When you add the platinum to cetuximab in that setting, you don't really improve results. Those are platinum refractory patients that this has been studied on. And on the other hand, if you look at retrospective historical data, maybe you do increase survival. Now, it has not been demonstrated a survival benefit because nobody has done a phase 3 trial in that setting. There's actually a phase 3 trial ongoing in the elderly patients comparing cetuximab with methotrexate. It's a small study. It's going to be looking at safety as well. And what about other EGFR targeted therapies? Panitumumab, as I mentioned to you in my previous lecture, has produced negative results. This is the Spectrum trial with many similarities to the Extreme trial. In this case, cisplatin and 5-FU was used, so there was no carboplatin in the regimen. That study showed improvement in terms of objective responses, PFS, but not overall survival. Again, panitumumab does not seem to be as active overall versus cetuximab, although there's no head-to-head comparison, of course, in head and neck cancer. In terms of the other inhibitors, zalutumumab, an interesting drug, but in this case was compared to best supportive care alone. Many got methotrexate in the best supportive care arm, no survival benefit. And then there were two studies with gefitinib, one gefitinib versus methotrexate, and the other, the one we run in the Eastern Cooperative Oncology Group, docetaxel plus minus gefitinib. Again, both studies failed to show a survival advantage for the experimental arm with gefitinib. And finally, a study that was recently published in Lancet Oncology compared afatinib to methotrexate. Afatinib is a dual inhibitor of both EGFR and HER2. And as you may know, it is approved for lung cancer, EGFR mutated lung cancer. In this study, actually it was a large study, it did show a hint of efficacy and improved PFS, but there was no difference in terms of overall survival. There are some interesting biomarker data that have been presented at ASCO, suggesting there may be more benefit in P16 positive patients and some other biomarker data of interest. But overall, afatinib is no better than cetuximab. Actually, it was a phase 2 trial comparing the two, and it's probably identical in terms of efficacy, so for sure not better. And in my opinion, it's more toxic than cetuximab. So cetuximab is easier in terms of the toxicity profile. And what about bevacizumab? Well, actually, our group in Pittsburgh has produced most of the data with the combinations with bevacizumab. Bevacizumab is approved for many other malignancies. In terms of head and neck cancer, we have those three trials, single-arm trials. In terms of chemotherapy plus bevacizumab, we have this trial with pemetrexed, and we did demonstrate a pretty promising survival, 11.3 months. This is numerically better than what we've seen with the Extreme regimen. This is, again, a historical comparison. So we're prompted to study that further, and we completed a phase 3 trial. This is actually, the design is here. This is the ECOG E1305 phase 3 trial comparing a platinum doublet plus minus bevacizumab. We elected to have 4 different doublets, either a platinum plus a taxane or a platinum plus 5-FU. So those are, we think, standard options. This was kind of started before the cetuximab era, so you don't see a cetuximab arm here. We're completing the trial without using cetuximab in the control. And the study has now completed accrual more than 2 years ago. We accrued 403 patients. I'm hopeful that we're going to present efficacy data at ASCO 2017. We have already presented our safety data. In terms of safety data, it seems that the addition of bevacizumab increases some complications, increases, as expected, some bleeding complications, but not to the point that it's unacceptable. So it's an acceptable combination. So the last part of the talk, I would like to mention what is really going on in terms of immunotherapy and how this is changing the field. Also, I need to point out that the data we have so far are for second-line therapy. So my topic is first-line therapy, but I need to mention what is happening on second-line therapy. And as you know, many drugs targeting the immune system are of interest. For head and neck cancer, actually, we may have had the first immunotherapy drug. We just didn't recognize it. So cetuximab clearly has a mechanism of action through the immune system, activates NK cells and ADCC through IgG1. In my opinion, this is an important mechanism of action. It has not been studied to the point really to understand it a lot in the clinic. And then we have the CTLA-4 inhibitors, first approved for melanoma. Now they're being studied in other solid tumors, usually in combination with PD-1 inhibitors. And then the agents that have made it to the clinic are the PD-1 inhibitors. We have pembrolizumab approved in the United States based on phase 2 data, and I'm sure nivolumab will follow because it has a positive phase 3 trial. So those are the second-line trials. We have actually reports of a few of them. The Checkmate 141 was a phase 3 trial of nivolumab. Also the Keynote 055 trial. This is a phase 2 trial, has been reported as well, and we have other phase 3 trials that we are waiting results. So what about those two trials that have reported results? The Checkmate 141 is published in New England Journal of Medicine as of October, just at the ESMO meeting. This slide shows to you the design of the trial. Essentially, it was for the second-line therapy, including early relapses. It was a 2-to-1 randomization, and patients were randomized either to nivolumab alone versus investigator's choice. And most patients got either docetaxel or methotrexate. Only 15 patients received cetuximab. That was an option as well. In the Keynote 055 was a single-arm trial of pembrolizumab that enrolled a very good number of patients, as you can see. In terms of the overall survival in Checkmate 141, there was improvement in the second-line setting again, 5.1 months in median versus 7.5 months. You can also see the hazard ratio here, very robust, and here at 1 year, 36% versus 17%. So almost doubling, actually more than doubling of the percentage of patients surviving at 1 year. And the Keynote 055 with pembrolizumab, kind of similar data, although this is not a controlled trial, showing a median overall survival of 8 months. And what about adverse events? They're different compared to chemotherapy. You see some specific to the immune system, but overall better tolerated than chemotherapy. And you see here grade 3-4 events, 13% versus 35% with chemotherapy. That's with monotherapy in Checkmate 141. And there's some interesting data regarding PD-L1 expression and the activity of nivolumab and pembrolizumab. Statistically speaking, it works for both PD-L1 positive and negative. It seems that there's benefit more in PD-L1 positive, but at this point, the approvals we're going to see include all patients. So there's no selection based on PD-L1. And if you look at both PD-L1 and P16, it seems that all patients are benefiting, but the ones that are benefiting the most are those groups, and the least maybe those who are PD-L1 negative and P16 negative. I think there's a small number of patients there, so only 14, so it's hard really to make conclusions out of it, but I think that's hypothesis generating. We need to have a signature really to predict what's going on in terms of the activity of those drugs. So I think combinations will be important as we move to the first line setting. That's why I mentioned to you the second line data, because we're thinking really, can we change the treatment of first line recurrent metastatic disease, and can we go to locally advanced disease? So combinations of immunotherapy with radiotherapy, chemotherapy, surgery, maybe as induction. Of course, with cetuximab, combinations are really of interest. And just quickly, the design of this trial, the Checkmate 651, this trial opened at least a couple of months ago, and this is in the first-line setting. The control arm is the extreme regimen. Again, first-line setting, we do think extreme is the control. And then the experimental arm is a combination of nivolumab and ipilimumab, so PD-1 plus CTLA-4 inhibition. And this has worked in melanoma. This is being studied also in lung cancer, so that type of combination. The investigators, and I'm involved in that study, thought that we need probably the combination to produce better results than the extreme. So maybe nivolumab alone wouldn't make it, but we need to see if two drugs are better than one. And actually, yeah. And so we have this study as well that it's in a little bit different setting, but includes some patients that could have been in a Checkmate 651 and compares the two drugs versus one drug. So we're going to see really if the response rates are increased with the two drugs at least. This is a smaller phase 2 trial. And that trial also includes early relapses. So those are patients who relapse within 6 months. So those are patients for this study as well. And we could include some first-line patients as well. So are we answering all questions in the first-line setting? Well, maybe not, but there are three major trials that are ongoing. The the Checkmate 651 I mentioned to you. There are two others that are near completion in terms of accrual. The Kestrel trial and the Keynote 048. The Kestrel and the Keynote 048 have extreme as the control. Again, all those three studies have extreme as the control, showing that in the first-line setting, that's the standard of care. I think that's an important message from today. But in terms of the experimental arms, the Checkmate 651, as I mentioned, has the dual combination. The Kestrel has a dual combination of PD-1 and CTLA-4, and then also has a single kind of monotherapy arm. And then the pembrolizumab study also has a pembro plus chemotherapy arm. So there's some differences in the design. So those two are three-arm studies. That's why actually they have a little bit higher sample size than the Checkmate 651. And of course, there are other questions that we may want to ask. Should we, if we give the extreme regimen, should we give immunotherapy during maintenance, for example? That would be of interest. Or you take the extreme regimen and you add immunotherapy to that. So this has not been studied as far as I know. So to conclude, platinum-based chemotherapy plus cetuximab followed by cetuximab maintenance is agreed upon as the standard of care in the first-line treatment of recurrent or metastatic squamous cell carcinoma of the head and neck. Platinum taxane cetuximab regimens are promising, and phase 3 trials are ongoing. Immunotherapy has a proven role as second-line therapy for patients who previously received platinum, and at this time, immunotherapy alone and in combination is currently investigational but actively being studied as first-line treatment of recurrent or metastatic head and neck cancer. Thanks for your attention.
Are there any questions from the floor?
Thank you very much for your lecture. And my question is regarding cetuximab regimen as a maintenance regimen. Which kind do you use, every week or every second week? And do you see any kind of differences in toxicity? And also the question, how should we use it? It is an approved regimen every 2 weeks, and could we this?
Yeah, I have to say, if you ask me what I do, I have to go by the book, and the every week regimen was studied in the extreme trial, so you have to do it every week. Now, if a patient asks you, doctor, you have given me too many weeks of treatment, is it possible to, because I'm coming from far away, can I just come once every 2 weeks? So you may accommodate that. So not during chemotherapy, but during maintenance, if someone asks you and wants that, otherwise he's going to quit. maybe you could offer every 2 weeks. So it's not wrong. Again, hasn't been studied as much in the TPE versus extreme. In the TPE arm, they allow every 2 weeks, so they're believers in that. In my opinion, I don't think it's going to be inferior, but if you go by the book, you have to do the weekly. This is the approved, at least, regimen.
To me, it is unclear why panitumumab does not work in head and neck cancer, because we know from colorectal cancer trials and clinical practice they are equal in first, second, or even main threat as mono.
A striking difference between colorectal cancer and head and neck cancer is that head and neck cancer is amenable to immune therapy. Colorectal cancer is not. So I think the difference, although I cannot prove it to you, may be that cetuximab is an immunotherapy drug, and that mechanism of action through ADCC and NK cells may be important, and that probably differentiated the two monoclonal antibodies. There may be other factors. So panitumumab is more EGFR targeted, and you see more rush, more kind of EGFR targeted effect. Versus cetuximab, you see that, but you also probably see an immune response to that. And again, it's not a complete answer because we don't have the data to support what I'm saying. But based on the preclinical and clinical information, it's reasonable to hypothesize that this is a difference between the two drugs.
One is chimeric, another one humanized antibodies.
Right, exactly. So it's also IgG1 versus IgG2, plus it's a humanized versus a human. So I think those are the differences that allowed the one to be as good, I guess, for colorectal cancer, but the other clearly not as good in terms of head and neck cancer.
I would like to ask questions regarding taxanes in first and second line. What's your opinion about that, and which more preferable, paclitaxel or docetaxel? Because Cortec and other trials show differences.
Yeah, sure. I'm biased because we developed the TPE regimen, so I'm biased towards docetaxel, but paclitaxel probably will have similar results. If you look at the development of those drugs for head and neck cancer, there's no much difference between the two. So I think either paclitaxel or docetaxel. I actually have used TPE for recurrent or metastatic disease. I think that's probably as good as the extreme regimen, and of course that's the topic of the Gortec trial. So to me it's acceptable to use a taxane even with the current data. Again, it's easier because it's just a day one treatment, and the toxicity profile is different and maybe preferable using a taxane. When you do that, I use GCSF, of course. You have to do that because you do see neutropenia more frequently than I think that the extreme regimen.
Or monotherapy?
Oh, for monotherapy, now in the second line setting, based on the nivolumab data, nivolumab is better than docetaxel. So it has replaced that as an option. When we thought in the past, what is a standard approach for second-line therapy, we did use docetaxel monotherapy. That was the design of the ECOG trial, docetaxel plus gefitinib versus docetaxel, thinking that it is an acceptable monotherapy for second-line treatment. And if you ask me what I've done, yes, I've used docetaxel as monotherapy, but am I convinced that this is better than methotrexate? Maybe not. Maybe not.
Do you use methotrexate in your routine clinical practices?
Yeah, rarely, but I think nothing has necessarily shown to be better than methotrexate other than nivolumab, based on data. Is that right? If you see older studies, even paclitaxel was the same to methotrexate in it was phase 2 randomized trial. So none has shown that methotrexate is a bad drug. In the study, for example, gefitinib equals methotrexate. So it is acceptable, although, we, at least, I was a fellow and I trained during the taxane era, so I'm biased because of that, and biased against poor methotrexate, but still is an active drug with some small activity, probably not inferior to the taxanes.
One more question. How do you manage your patients with metastatic head and neck cancer in your routine clinical practice? What would be the optimal sequence?
Yeah. So first line, clearly the extreme regimen or the TPE. That's what I tend to do. First line. Second line, we do have nivolumab, or we try to get nivolumab or pembrolizumab if we can. It's not approved in Greece. It's not approved in the EU, as far as I know. But we try to get it. We recently applied for, to get nivolumab for a patient. If not, as we mentioned, a taxane, if the patient didn't receive a taxane, or cetuximab. I've given monotherapy with cetuximab for second-line therapy. This Checkmate 141 trial was so important because we did not have good options for second-line therapy. Because all those drugs lead to poor survival in the order of 6 months. That was shown in Checkmate 141. The control arm performed as expected, because we've seen that in so many clinical trials. But with nivolumab, you go to close to 8 months, and that's exciting. And I think we can even do better than that with combinations, nivolumab and ipilimumab, for example.
Thank you very much, Professor, for sharing your knowledge. Thank you.